So we've heard some extraordinary sessions already this morning. And obviously the session we've had just now may have brought up difficult things for some people. If anyone does find that they are struggling today, we have two people here who are very experienced who have offered to talk to anyone who feels they need someone to talk to, and they are Dorian Espiritu and Sarah Moore. If you could wave, there's one. Where's the other one? Is Sarah Moore in the room? Okay, she's sitting there when she comes back. Okay, and so, yes, Sarah is the other person who's very kindly agreed to talk to people if they would like someone to chat to. So do search them out in the breaks if we want to. Now, we're turning next to a topic which, at first sight, might feel like the polar opposite of hearing people talk about their emotions and their experiences, and that is artificial intelligence. But are there ways of using AI and machine learning and apps in this space to prevent just the kind of tragedy we've been hearing about? We have a panel, and I'd like to invite our panel to come up and take seats here. We have Newal Roy, who is founder and CEO of Holmusk, also described as a pioneering force in AI-driven healthcare. It's good to be a pioneering force. And Dan Joyce, who is Professor of Connected Mental Health at the University of Liverpool. Welcome. And Bobbi Jo Yarborough, who is a clinical psychologist for Kaiser and Health Services researcher. So please do join them up here. And I'd also like to welcome back Professor Joe Rafferty, who will be facilitating this session. Thanks, Joe.
Thank you very much, Claudia. It's only 2 words of introduction from me. It's an interesting title. We want to generate a lot of debate around this. 2018, I think David Covington and I, in the back end of the Rotterdam conference, said, you know, there's something going to happen in the world around, I don't think the phrase artificial intelligence was, maybe it had been coined, it certainly wasn't something I knew about. But we talked about machine learning, big data, the ability to connect data in a very different way so that we would generate really different insights. And I think it was interesting that a number of the sort of policy speakers this morning also spoke about the importance of not just having data, but connecting it differently and seeing and driving different insights. So this won't be a set of presentations that talk about using AI and machine learning to predict individual risk of suicide and those types of things. It will not be a presentation where we'll talk about machines will take over. But I do think we need to begin to think about the implications of this in the suicide prevention world and how we can augment, I think, for zero suicide in healthcare clinical skills. How do we bring together data that gives our practitioners lots more instant insight to a scenario, to not just the person set in front of them, but a sort of persistent longitudinal view of the relationship with healthcare. And of course, beyond healthcare, we're now beginning to connect data in this city around social care, education, relationship with the justice system and so on. So over time, we can begin to paint very, very different pictures. So the objective of today is to try and get into a set of presentations about what's possible, what's not possible, what's desirable, what's certainly not desirable. And hopefully we'll have time at the end of it for us to draw some sort of view from the room as to whether or not, as a zero suicide community, we should think about how to spend a bit more time on this. So I'd like to introduce Dan to kick this session off.
Hi, folks. Thanks so much for having me here. It's a real privilege to be here. Just so that you know, I don't work in suicide research. I'm, depending on the audience, I'm a psychiatrist who used to be a computer scientist or a computer scientist who is now a psychiatrist. So what I'd like to talk to you about is opportunity for advancing where we are now. So these are 2 recent analyses of the performance and success of using machine learning and AI in the area of, and I'm going to use this term deliberately vaguely, suicidal prediction. My reason for using it loosely is because this is the problem. If you look at the data contained in these two systematic reviews and meta-analyses, you find, this is the striking finding. After 15 years of effort, what we find is this, is that we can't get our accuracy up beyond about 70%. We focus on discrimination metrics, which I'll come back to in a moment, but essentially, we use the term prediction, risk, and clinical decision support so loosely that it's become almost as meaningless as the phrase AI itself. So the key messaging here is it turns out no matter what data you use, be it electronic health records, be it administrative or insurance data, or survey and population data, when you throw AI at the problem, the best you can get is sensitivities and specificities of the order of about 0.7, 0.8. If you use different machine learning algorithms, be they random forest support vector machines, deep learning, neural networks, multi-layer perceptrons, it doesn't matter. The best you can still achieve is around 0.6 or 0.7 for sensitivity and about 0.8 for specificity. So have we reached a hard limit? One of the answers to that question is no, because we now have large language models. So you'll all have heard of ChatGPT. So ChatGPT and models like it are similarly, in my humble opinion, being deployed with this very vernacular use of clinical language. If I can draw your attention to this recent evaluation of Replica. Replica is a ChatGPT type bot. It forms a relationship with its owner, and then it supposedly helps them with things. But the evaluation of this, and this is why I think language is so important, the evaluation of this showed that, or at least the way the evaluation was written up, was that it mitigates against suicide, that by engaging in what seems like therapeutic interactions, it led to the diagnosis and remediation of mental health issues. Nothing about that rhetoric is supported in the paper. It's an evaluation of just over 1,000 undergraduate students at a fairly prestigious US university. They used a loneliness questionnaire and did some qualitative interviews. But notice that the language being used to report that evaluation is the language of causality, that it was an intervention, and that there were people there who were a differentiated clinical population. And none of that's supported by the data. So one of the reasons I think we've hit this apparent hard limit is because we treat clinical decision-making as if it were classification. Classification in the engineering community means to decide whether or not an input belongs to one of two or more mutually exclusive classes. So to give you a concrete example, whether or not someone will die or did die by suicide in a 3-month interval or not. I don't think that's an appropriate use of the term prediction, risk, or indeed classification, I may argue. But here's an example that I'm going to draw upon as we go forward. If we assume that we know what the rainfall measurements were for the last 5 or 6 days, what prediction means is to make a forecast about the future. That is to say, I want to predict what the rainfall will be tomorrow and the day after. So the data I have to train an AI or a machine learning model enables me to make a prediction about the future rainfall. Rainfall is a number between 0 and infinity in millimeters of rain. The only reason for making a prediction about tomorrow's rainfall is so that I can make a decision on the basis of that. So classification ignores this subtlety. What we need to do is reintroduce that subtlety and start focusing on models that explicitly account for this. So the hard limit I showed you in those 2 papers is a function of ignoring what we're doing prediction for and then how we're using those predictions to make decisions. So we need 3 components. The first component is a parameterized model or an algorithm. And that, as I've just shown you, can be pretty much anything you'd like. Then what you need is a decision rule, which is the actual decision you're going to make. And then finally, and most importantly, you need what's called a cost or utility function. So in that bottom right corner, you can see a matrix. What this matrix tells you is if the outcome tomorrow, I predict that there's going to be light rain, so I decide not to take a coat, you can see in the bottom left corner, if my decision is to do nothing and there is heavy rain, I'm going to get punished heavily for that decision because I'm going to get soaking wet. In contrast, in the top right of that little coloured matrix, you'll see that if I decide to stay home and the actual outcome is completely dry, well, that was the wrong decision, but it wasn't the worst decision, so I'm going to get a slight punishment for that. My boss may be annoyed that I didn't turn up for work. But here's the important point. Utilities, or costs, represented in that matrix that I've shown you there, are not symmetric. Yeah? The cost of not doing something is not the cost of doing something, or the consequences of not doing something. So here's a concrete example for you. I take my predictive model, my parameterized model, and it shows me that the most likely level of rainfall is that big, thick purple bar, but there are also probabilities associated with different levels of rainfall, shown with those kind of light pink or light purple bars. What I'm going to do is I'm going to use that information, those predicted rainfall levels, to inform my decision. So I'm going to consult my decision rule, which says, most likely, you need to take a coat. Yeah, but you might want to consider staying at home, taking an umbrella and a coat, or doing nothing. But here's the important part. You have to run that information. That putative decision has to be run through the utility or cost function. And as I've explained to you, it's not symmetric. So what you do is you weight the most likely decision based on your predicted rainfall, and you give that more prominence, more weight than you do the less likely predicted rainfalls. And then that means you can do this. You can take a weighted average over all of the decisions that you could make, and then you pick the decision. The optimal decision to pick is the one with the least cost and the highest utility, so the best score. So that's how you should, in my humble opinion, marry the mechanics, if you like, the sort of algorithm or mechanics of this problem with clinical decision making. So here's why I think we've hit that hard limit and what we're doing wrong. First of all, we mistake prediction and risk for being things that they mathematically are not, and we assume it's classification. We look for candidate predictor data opportunistically. We happen to have it lying around. It's in the EHR, or we did a survey 10 years ago. We could reuse the data. And then we look at the consequences, not the outcome of interest. So what I've done here is I've replaced those outcomes with vague proxies. So getting drenched, being damp, or staying dry. Remember, in the previous slides, my point was there's uncertainty that needs to be accounted for, there's a decision rule that needs to be accounted for, and then there's an asymmetric matrix of utilities that need to be accounted for. Only when you studied all of those things and parameterized them or made them mechanical can you say you've got clinical decision support. But we don't. We shortcut it. What we try and do is take opportunistic data and marry it to consequences in a very straightforward way without accounting for those intermediate steps that I've just articulated. Second mistake we make is classification itself. To coerce our complex clinical data into a format that we can use with the available low bar to entry machine learning algorithms we have available, we take a number of outcomes, bunch them together, and just say, well, we'll call that class 1. And class 1 is any outcome that happens to mean you get wet. The other class, class 0, is everything else. So we dichotomize outcomes inappropriately. We do that because it means we can coax or we can coerce into the standard ways of evaluating classification algorithms. So you might remember on the first slide, I showed you that we used all those papers, those 2 meta-analyses and systematic reviews, all used area under the ROC curve, sensitivity and specificity. These are discriminative metrics of performance only suitable, and barely at that, suitable for classification problems. So if we can coerce our output, our outcome of interest into that format, we can then form that matrix you see on the right there, which is the confusion matrix, From the confusion matrix, you are then able to define sensitivity, specificity, area under a ROC curve, F1, recall, precision, any metric that you care to name. But you have to force your problem into a yes-no outcome. So here's what I think we should be doing. So to recapitulate what we've just been talking about, at the moment we start on the far right. We find talented, gifted engineers, computer scientists, and we say, I've got some data, can you model it? And we then publish papers that talk about risk prediction or predicting events of interest. I would suggest that we start on the left side of this slide. First of all, we need to enumerate the outcomes that we care about. That should involve stakeholders, services, population health experts, and we should identify the intended use case. What are we actually trying to achieve? What outcome do we want to achieve? The next step is to enumerate all of the actions and decisions that are available to us. So if we want to prevent an outcome, we now have to enumerate the decisions or actions available to us that would prevent that outcome. To do that, we need best practice guidelines. We need clinicians who actually will use the tool, and we need to know who the tool users will be. Once you've done that, you then need to build that matrix of utility or cost. So we need to articulate for every decision outcome pair what the cost is. And remember, it's asymmetrical. The cost of a true positive is not the same as the cost of a false negative. And they're not symmetric just by sign. It's not like you get +1 point for getting it correct and -1 for getting it incorrect. It's not the case, particularly in high-stakes, life-changing decisions. Right at the end of this process, you then need to ask yourself, what data or what event data do I have that would support those decisions? If you can locate that data, can you curate it in a meaningful way? And finally, we shouldn't be focusing on classification metrics that assume a yes-no decision. Okay, it's way more complex, as I've hopefully tried to convey to you. So this is my take-home slide. So prediction is not classification. Decision-making is not classification, and risk is really, or not really, it is the product of the probability in an event multiplied by the magnitude of the cost of the outcome. Precision of language matters. Too often the AI community leans on vernacular interpretations. The example I gave you of replica, there is nothing in that analysis that suggests that it was a causal intervention, or it was an intervention that was causally related between someone developing difficulties with suicidal distress and preventing them coming to harm as a result of that. Nothing whatsoever, but it was sold as mitigating suicide. That, I think, is probably on our engineering colleagues to be a little more prosaic with how they describe it. So finally, if you know the deployment context, you can articulate the outcomes you really care about, you can articulate the decisions that would affect those outcomes, and you can estimate the cost and utility. Then and only then should you sit down in front of your computer with a copy of Python and some of your favorite libraries and start hacking machine learning algorithms. Thank you.
Thank you, Dan. That was amazing. Let me get to my presentation. All right. So I'm Newal Roy, founder and CEO of Holmusk. First of all, I want to be extremely thankful to Joe for having me here. I'm not sure why, but I'm not an expert on suicide. I'm not even a psychiatrist. I'm not even from healthcare. Okay? I don't even know healthcare. So the question comes down to, what do I know? I do know data. And what we have built is the largest data company focused on mental health. Holmusk is that company. I'm trained as an economist. I have spent 20 plus years in finance, and for the last 10 years, I have been thinking about nothing but mental health. Okay? And so if you think of the world in which the construct or the visions of the goal of what you are trying to achieve, and the construct of, think of Dan as an architect, think of me as a general contractor / plumber. This is a plumbing machine, okay? What we have built is the state-of-art industrial grade, industrial scale, scientific grade machine that can solve the problem if you are having the right resources and the right commitment and the right willpower. Okay. What goes behind it? This data is known to all of you. I will be preaching to the choir if I say anything else. Okay. The topic that we are dealing with is super complex. Mathematically and scientifically, it's a super complex problem. To some, it will even say an unachievable goal. Zero suicide is almost impossible to achieve, but the goal is extremely worthy, and anything closer to zero will be amazing, amazing goal for the society and for all of us. Okay? Here is a construct by which you can think around it. Okay? The real-world data that, as it exists in the current form, is usually into these 4 or 5 buckets, which essentially gets converted into 2 buckets. One is the structured data, the second is the unstructured data. We have all learned the art of managing structured data. What we haven't learned is the art of managing unstructured data. Unstructured data is where all the things come around, where it is your personal diary, whether your emotions, whether it is observations by the clinicians, social workers, what have you. How do you mine all of that is where the secret sauce lies. Okay. Doing it is the very first attempt of what we have built is NeuroBlue platform. NeuroBlue is essentially currently, as it exists, has approximately around 30 million plus patients live, mental health patients, only mental health patients live, all across different mental health disorders. You'd be surprised, usually depression is the largest predictor behind mental health. Anxiety disorder and depression is one of the largest predictors behind it. Thinking behind that is we can give you all the details behind it, and I'm more than happy to share this. What goes into it is how do you extract the data from electronic health record system? How do you fully de-identify them so that the personal identity is completely removed? And how do you harmonize them by scientific grade OMOP standard, which is a technology that's used by any kind of data scientist who is working so that you can really query the data and come up with any kind of policy goals that you might have. Okay? This is where the common data model of what we have built comes into the picture. This is the first brick that you put when you are going into building a data model. This is where it is very hard from the science point of view. You want to be scientific rigorous. Making this has never been done in mental health community. It has been done in cancer, it has been done in metabolic areas, but it has never been done in the behavioral health / mental health community, okay? Because it is expensive. Okay, it is scientifically expensive, it is capital-wise expensive, okay? And doing it is hard task, okay? You need 50 of DANs, and even then, you won't be able to get to it. It'll take you time, it'll take you dollars, and it'll take you real commitment to get there. We have done some degree of success. We have done more than 100+ scientific abstracts, publications, real use cases of the value that we can deliver. In community care, Joe will tell you that we have delivered value for Mersey care, and if it is scaled, it can really do at a national level. It can do really at different parts of the world. It is doable, but it is hard. That's what I'm trying to say. I can go on and on around the complexity of how NLP can be used. Is it a miracle? Probably not. But is it a path to the solution? 100% yes. Okay. I want to rush through and show you the values that we have delivered for different sectors, whether it is pharmaceutical sectors, whether it is for hospitals, and these are the 2 different, if you truly want to understand cognitive impairment, what goes behind the mind of his suicide ideation, okay? And this is usually for schizophrenia patients. you can understand and literally understand the phenotype of the patients who are suffering from this, okay? This can be done literally in terms of for the phenotyping of the patients. It's a doable and solvable task. What it requires is the level of the detail of the data that you need and the computational power to truly understand that is it all white noise or is there a predictive value in that, okay? The science is there, the tools are there. Doability is a function of the data sources, the data curation, and literally the policy recommendation. The second one is all around, can we even predict psychiatric hospitalization, okay, which is directly linked to the hospital system. We have published this, in the Lancet paper, very, very solid. These two are only giving you a sense of what is possible, okay? I can give you many more lists and many more examples of this, but what I'm giving you is a sense of what we have done is the curation of clinical data, okay? Clinical data is electronic health record data that every hospital system in the advanced countries has it. If you take the data and link that with additional data, whether it is claims data, registry data, omics data, all of a sudden it becomes scientifically more complex, but much more predictive value power, okay? And it is to be done, it can be done, that's what I'm trying to say. What does it mean? Let me give you a very realistic picture of the world in terms of what it takes to do it. When I started building this company in 2015, at that time I was fully influenced by having spent 20 years in finance of a product called Bloomberg, okay? Bloomberg currently sits on the desk of every major finance guy in the world, okay? That was my vision because I knew what the data as a utility can do to solve the problem. I had this in my bone for the last 20 plus years. I started building NeuroBlue. It has broken my back to build this company, okay? I have raised more than $100 million to build this company. I have spent 70 million so far, okay? So many data scientists and so many unwavering hours towards the commitment towards mental health, okay? What you are seeing is a database that has lives of 30 million patients, more than 100 plus publications, and every possible partners like Joe that you can think of. It is doable task. I'm giving you a version of the future, which is Neuro LLM. But I'm also attaching the price tag. The cost is $500 million to $1 billion, okay? But I want to leave this on a very, very positive note, that what you are trying to achieve is a very human goal, and we, in this day and age, deserves that goal. It is doable, but it requires commitment, dollars, and time, and hours, and true leadership. That's where I'll stop.
Okay, I have very little time to tell you about several research projects we've been doing over the last several years. Some really important work thinking about whether and how we should implement suicide risk models, and hopefully we'll get enough time to talk about a clinical trial that we're in progress of right now. So we know in this room, based on these presentations alone, that there's increasing interest in suicide risk prediction or detection using novel methods, including models derived from electronic health records. Relative to clinical assessments, we talked throughout this conference about the PHQ-9 being used as a screening tool, particularly 9th item. These models have superior accuracy in terms of identifying at-risk patients. But when we started this work, there was very little information on patient or clinician perspectives. There were no implementation guidelines or practice standards, and no evidence of actual benefit of these models. So We know these models are being implemented in various settings. We need to develop quality measures to ensure the risk models are implemented effectively, fairly, and safely. We need to shift the emphasis of prognostic model research. A lot of that research has been done. We need to shift that closer to the clinical setting and address questions of practical applicability. And we need to, importantly, better understand the perspectives of the end users of these models. As we were thinking about beginning this research, there were many potential ethical issues that we were considering. First of all, how do patients feel about this use of their healthcare data? Do they feel like this is a legitimate use of their data? Do they think any differently about this than they do all the risk models we already have that predict cardiovascular disease, cancer, other health conditions? Should patients have to consent to their data being used for this purpose, or should they at least have the option to opt out of this? What about the limitations of EHR data? We've heard a little bit about that this morning. Is there a potential by doing this to create or exacerbate healthcare disparities? We have to be careful about that. What do clinicians need to know and understand about how these models are developed? What predictors go into them? What is and is not included? The populations that they're developed and validated on? How much of that information do they need to know to be able to use them effectively and explain their use to their patients? And how should we determine the threshold for who's at risk, since we know that that's a continuum and it's not something that's constant over time? Will resources that are directed to at-risk patients be diverted from people who are determined not acutely at risk? And how do we think about that? And who should have access to risk scores from these models, given this is private and sensitive information? And should there be some kind of oversight committee or governance committee that's moderating use of these? So I can't talk about each of these projects, but I'll say that the results that I'm about to present are based on research that's been funded through the National Institute of Mental Health. These include formative focus groups with patients and family members, a survey that was sent to patients with and without histories of mental illness or suicide behavior, consulting with bioethicists and patient advocates, and then key informant interviews with the patients and the other groups that you see here. I'm going to move through these really quickly. So some of the things that we found on our survey that are important, we wanted to know, I said earlier, what patients think about the use of these kind of models. If we can get to the place where we have a model that we feel confident in, should we use it? What do patients think? And we asked, rather than like, is this a good idea or not, we wanted to understand, relative to the way that clinicians currently assess risk, how appropriate is this? So you can't see, these are cut off. I think the first one is like, that's interesting. This is not what my slides looked like before. Okay, the point of this is, I think the first one that says 89 here and 88, these are compared to a clinician reviewing the electronic health record, so looking through their records. 89% of people said that's acceptable. Compared to the primary care clinician asking them directly, 88% of people said that's acceptable. These are other, ways that are commonly using mental health screening tools. I don't know what this MH one is. That's your mental health clinician, your therapist asking you directly about risk. And the last one is using EHR-derived risk models, which is 84% of people. So you can see that it's within range in terms of acceptability. We know, I acknowledged earlier, that the predictors that are included in electronic health records are limited. We don't have important events like whether or not someone was recently divorced or lost a family member, whether or not they've had a bankruptcy, whether they've had any of these major life events that can really put people at acute risk. So we asked people, what if we use public health data and we combine that with the electronic health record data? If that could improve prediction, is that appropriate? And you can see that the acceptability went down dramatically. So the patients that we spoke with and in the survey indicated that they did not feel like that was an appropriate use of their data for health systems. And this next slide, oh my goodness. Okay, those should be pie charts. I don't know what's happening. 70% of our sample told us that they thought those other risk factors that I just mentioned were very important, but only 50% thought that they should be included in health record risk prediction models. So that's 50%. I don't know if you're a glass half full or half empty kind of person. You could say, look, half the people think it's a good idea to do that, and half the people don't. So that's where we're at. patients told us very clearly they were comfortable with their psychiatrist or primary care clinicians or mental health clinicians talking to them about this risk. But if you think about a zero suicide approach where any encounter in the health system might, trigger someone to be asked about their suicide, they were very clear that being asked by anyone they were not comfortable with. They were not comfortable with medical assistants or nurses, or not as comfortable, I should say. So let me talk about clinician perspectives. I was going to spend a little bit more time on this, but I'm going to skip through it, except to say that the models that we are using in the context of these studies were developed by a group called the Mental Health Research Network. They were developed on a large data set. You can see 20 million visits by 3 million patients at 7 large US health systems. The area under the curve for those models, despite different ways of using different sources of data, is generally between 0.83 and 0.86, so it exceeds some of the earlier limits we talked about. So when we're talking to clinicians about the use of those particular models, this is just a summary of some of the things that we've heard from clinicians. I can't read all of these. I did put the citation at the end if you're interested in this, but I want to highlight a few things that have already come up in the conference that are consistent with what we found in this study. Mental health clinicians and primary care clinicians want to know early about potential use of these things. They want to have buy-in. They want to be involved in how these things are going to be implemented in health systems. So it's important to create opportunities for that. Another one that I found really interesting is they think it's really, they think about these models differently than they do a screening instrument. They're a lot more concerned about liability. So, if we use screening instruments to direct who we should or shouldn't follow up with, clinicians are fairly comfortable with that. But when we tell them we're going to give them a model that's actually meant to make their lives easier, it's going to condense all this information that they would have to read in the electronic health record, and it's going to deliver a score, or it's going to show them a flag that says, this is just an indicator. We're not telling you what to do, but we do think you should pay more attention to this patient who's going to be in front of you in a few minutes because they look like they're at risk. For some reason, they feel a lot more wary about what will happen if they do or don't do the right thing next. So that's something to be really considering when we're thinking about training clinicians. Check out this paper if you're thinking about adopting these kind of models. From all of these different interviews and surveys that we've done, we started to put together an ethical framework. The citation is here if you'd like to see that. The ethical framework addresses these 6 domains. Again, I don't have time to go through all of them, but you can see some of the key components within each of them. And the goal of the ethical framework is that people who are considering adopting suicide risk models in healthcare, we ask that they would discipline themselves to ask a set of questions that are a part of this framework and to just think those through prior to implementation and during the course of, in sort of a recursive manner. And so I'll give a couple of examples. So within autonomy, so we know that right now, if patients are being screened with a questionnaire, they have a right to conceal or disclose their risk. They get to make a choice. But when we move that into a learning model that tells the clinician this person is at risk, and even if they deny it for a variety of reasons that might be very valid, you should still follow up with them and still check in on them. So we need to think about that, the tension that creates, that we're reducing some of that autonomy and we're justifying that with the protection we think these models are, and what you'll do as a result of these models is offering. Let me just pick a couple more to highlight. Have we thoroughly, under non-maleficence, have we thoroughly considered and mitigated possible harms? So how will the health system monitor and respond to unintended consequences? How will you even know if there are unintended consequences, negative consequences, and what would cause us to stop using these? And I mentioned, should there be an oversight committee or something? We know that models drift over time, so there's going to need to be someone who's continuously validating them and making sure once some of the we would hope that if someone's at risk, they get diverted into appropriate services, and those services then become predictors in the model, and it's sort of cyclical, so someone needs to be stewarding that model over time and making sure that the health system is thinking about those things and has an investment in that. We've done a lot of implementation planning because, as I said, we are right in the middle of an ongoing clinical trial looking at whether or not use of these models actually improves the outcome. That's like the most important thing, right, is we can be really excited about these models, but if they don't actually reduce suicide attempts and suicide deaths, then they're not very useful to us. And so we've done a lot of planning with clinicians and health systems that are involved in this study. We asked our adopters to think through, because again, this has come up throughout the course of this conference, that one setting is one setting. Things that happen and can be applied to one setting can't necessarily be applied everywhere. It's not a one-size-fits-all sort of thing. So part of the process is looking at the barriers and facilitators within the unique system that you're in, so that you can plan implementation strategies that leverage those, so that you're taking advantage of and exploiting the facilitators, but you're also very aware of the barriers and trying to address those, and doing that in a way that you can see a clear mechanism to the outcomes that you're trying to improve. So in the trial, we're looking at whether or not use of these models increases above and beyond what was being done in usual care before, identification of people, the number of people who receive risk assessments, and the number of people who receive adequate and appropriate clinical care that's focused on suicide prevention specifically, and then whether or not in the end it ultimately affects suicide outcomes. So you can kind of see through this logic model how to think about that. I won't talk much about this, except to say in the course of the randomized controlled trial, it's a pragmatic trial, so we've got different sites making different decisions about where to set their risk threshold, how often to run the model, where the data comes from, what type of intervention is going to occur, how clinicians are trained, and that variability is it's what's going to allow us to see and make recommendations about how to do this. Here's an example in one of the settings of. So all three of the sites that are in the clinical trial have decided to put an alert in the clinician view of the electronic health record. So it's just a warning indicator to the clinician to say, like I said earlier, pay a little bit more attention to this patient. So this is kind of what that looks like. And then I'll just skip to this slide, which is really busy, but it's just sort of a picture of what I talked about earlier. So the top part of this diagram is kind of what you might expect to happen in a typical healthcare workflow, that someone would come in, they'd be administered a screening instrument, they're going to answer the questions. In this case, I'm using the example of the PHQ-9 because we've talked about that here. So that might be missed, it might be refused by the patient, they might say no when really they are at risk, they might say no when really they're not at risk, they might say yes when they are at risk. So any of those outcomes can happen. What I'm showing in red is sort of where the workflow might end, and in green where a person would advance to the next step. So if they say that they're at risk, then they're probably going to hopefully get a risk assessment, and if they continue to look like they're at risk, they're going to hopefully be referred to services. Maybe they'll receive crisis services, and there will be some outcome. There will or won't be a suicide attempt in the whatever follow-up period. The bottom half of this diagram is meant to show what we hope will happen with the risk model, which is that even if someone missed the screening item or refused it or said no when they meant yes, the clinician will because they will have seen that little indicator and will have kind of been given a heads up, they'll spend a little bit more time with the patient and maybe do a little bit more assessment, maybe think a little bit differently about services. And so this is what we're going to measure in the clinical trial. And I will stop there.
Thank you so much for all of those, and thank you all for your timings there. Joe, I wonder if you want to come up and have a few thoughts. Do you have any thoughts on what you've heard before we take questions? And we can have a little longer, so we can have 10 minutes for questions.
All right, thanks very much. Just very quickly, I think the proposition today was to see, can we think about a sort of set of nested frameworks that we might be able to use to take this sort of work ahead in a productive way. So I think Dan, to use Newal's reference, an architectural framework. So could we get and think about agreement on, and there's quite a lot of discipline, I think, needed in and around that. The data science, the data plumbing framework, and just making sure that I think there's a huge opportunity, I think, emerges through Newal's presentation that many of the items that Bobbi Jo said, well, we get them from the EHR, but there's lots of stuff missing, is probably, in many instances, set inside the unstructured data. But to get it out of unstructured data in a way and scale that's meaningful is is not practical for most of our organizations to engage on until you get the sort of data plumbing at scale. And then I think it came together brilliantly with the ethical framework piece, which says, even if you can do all of this, should we do all of this? I think in my head the answer is we should do lots with this, but with the caveats that that ethical framework clearly puts in place. But I'm left with a feeling of, if we start to aggregate this type of thinking, we could radicalize dramatically our understanding of context. And I think, you know, when I heard Ursula and the dads talk this morning, I thought, actually, there's something about context here. Most of it's invisible context. It's things that's going on that may be recorded, leaving digital footprints. And I think we start to see the emergence of a potential solution to that. But I love Newal's $1 billion slide. You know, I'm thinking, where am I going to get that? But the point is, you know, it's a high entry cost activity, this. And, you know, one of the things I think we mightn't talk about it in this session, but we might think about it as a thing that I'll go back to Dave Covington and I talking about this many years ago. Is there a power of collaboration in this, which not only brings minds together that we've just heard today in a fairly ad hoc session, actually, which I thought, you know, drew out so much connected thinking. But is there a connected piece of work that we could all sign up to and begin to reduce those overall entry costs? And I think, too, that is there something that we could do as a community that would begin to think about in those frameworks, what are the standards we expect in those frameworks so that there is a sort of global standard that organizations may want to apply to? Because I've seen global standards work in lots of other industries, and they tend to drive huge value. So that's all the stuff that's been going on in my head while I'm listening to these three, but it would be great, Claudia, if you'd capture the questions from the room.
Yeah. So, yes, perhaps if you could join us just there. So has anybody got any questions at all? Do put your hands up. Oh, we have some on here. Oh, interesting. So this is an ethics question, so I think maybe for you. The ethics debate around tech often focuses on what the ethics are of doing this, with an underlying negative weight given towards avoiding any form of risk. Given that many technology initiatives in suicide are being designed to try and save lives, should we shift the ethical debate to what the ethics of not doing it would be, and weighing those with trying to make them as safe as possible?
Generally, I try not to take a position on the ethical thing. I think it's important that we just are weighing that we're thinking about that. Whoever put that comment in, I agree. We need to be thinking equally about the benefits as well as the risks, and not be risk averse, especially in this high stakes situation.
Then we have some questions for people who are not on this panel, so I'll not be doing those ones. Yes, the others are for earlier panels, in fact. But yes, there's a question just over here.
This is for Bobbi Jo. So I'm just wondering if you can say a little more, Bobbi Jo, about you know, in the context of the interviews you did to develop the stakeholder framework that you put together. If you can talk a little bit more about I guess, you know, placing suicide risk prediction in the context of all of the other things that we do to identify risk. You know, I think that there's benefits and potential consequences to all of those things, right? We know that patients are potentially there's a lot of fear on liability on the clinician side for not doing something. And on the patient side, there's, you know, I feel like something that comes up a lot is fear of negative consequences of disclosing suicidal thoughts based on, you know, things that have actually happened, right, to a lot of folks. I'm just curious if you can say a little bit more about, you know, not necessarily take a position, but just other things that you heard that, you know, maybe we should just be, like you just mentioned, be conscious of as we're thinking about moving into this world, and maybe based on your existing experience actually implementing these models.
Julie, can you Yeah, what specifically?
What specifically? I think I just would love to hear you say a little bit more about, like, just anecdotally, like how how clinicians, feel about doing this work, like as they're actually doing it. I think
clinicians.
Clinicians and like patients. If you're able to get any of that from the work that's actually happening now.
So I went through that clinician recommendation slide pretty quickly, but one of the things that clinicians have said to us is, prove to me that this is going to be like any better than what I'm already doing. I spend a lot of time. I'm really careful. This is really important to me. They're enthusiastic about the value of a risk model, like I said, pulling all that information together and giving them something actionable, a prompt to look a little bit more closely. But they also want to understand, like, how is this going to be any different than what we're already doing, which is why that clinical trial is so important. It may not be, so we need to find out. Patients, we had a lot, you were talking a little bit about negative consequences. I think you mean like involuntary hospitalizations. People are often very reluctant to identify and reveal risk because they're worried about the personal consequences to them. So in our focus groups where we were talking with patients, we were asking them questions, like I mentioned about, should people have to consent to this, or should, we made it really clear to people, if we ask for people to consent, there will be people who refuse consent who are high risk. So what do we do with that? And most patients that we interviewed and spoke with, and the majority of the people that responded to the survey said, even in spite of that, we should be using these models if they can save lives or if they can improve. So again, we need to know that they can, which is why that clinical trial is so important.
Yeah, there was a question over here.
Hi, I'm Shelby Rowe, Director of Suicide Prevention Resource Center and a suicide attempt survivor. And I think we have to be really, really careful with the ethics of this because it is a little different than cancer. Because if you get a cancer diagnosis and they say if you don't get treatment, you will die, and you go, okay, and go home, they let you go home. With mental health conditions, there is active discrimination. You lose your autonomy. And knowing that at least the current state of medical records in the U.S. around mental health are poor, very poor, and it's a garbage in, garbage out. And so if we train an algorithm on garbage, we're going to get garbage results. And so one, optimistic of, if we were going to record the records with as much standardization, removing stigma, discrimination, prejudice, but being someone who has been high risk, and anytime I change doctors and you have the lifetime form, the way the nurse and the doctors look at me when they walk in, because I'm honest about having PTSD, even though I'm a professional, I'm educated, I'm a functioning, healthy member of society, I have to convince my healthcare providers that I am each time I change doctors.
Thank you. I think you just said a mouthful. You said a lot. That was a really good representation of what we heard from a lot of patients in the focus groups as well. And when we use that like handy phrase, garbage in, garbage out, I think it's really important for us to think about what we mean by that. So we know the health records are incomplete. We know there's potential for bias. We know there's a lot of potential problems. So this is where the clinician training and the use of these models becomes really important, both helping clinicians understand why their documentation matters and what they document, because that becomes predictors in these models, but also helping them to understand we're not suggesting that these models should be like, you sort of warned about this. If a model says someone's at risk, that doesn't mean you go immediately to hospitalization or removal of rights. It means you pay closer attention. So one of our colleagues has a really, for me, this is cutting in and out. Are you guys experiencing that? Okay.
Sounds good.
Okay. One of our colleagues has a really good analogy of using these models the way that you would think about the risk, the indicator light in some of the newer cars. I'm not fortunate to have one of these cars, but a lot of cars will have a rear view mirror that lights up if someone's in your blind spot. So it's not telling you whether you should or shouldn't change lanes, but it is telling you should pay closer attention. And that's the way that we try to train clinicians to think about these models. We're not telling you that you should escalate care immediately or remove privileges or do anything drastic. We're saying, hey, there might be something in your blind spot. We're asking you to pay closer attention. And the clinician and the patient still reserve the right to make a shared decision about what happens next.
And Newal, you wanted to come in on this.
Yeah, I keep hearing the question that is just posed around garbage in, garbage out. Let me clarify 2 myths. This is the best garbage you have got, okay? And not having any garbage or any data is not the solution, okay? Clinical record system is the best clinical data that is out there. Not having any data is worse than even that data. So the solution is not really pointing out that since the data itself is bad, it means we can't solve any problem. The solution is literally treat suicide risk like any other healthcare risk, like cancer risk. There shouldn't be any penalty of disclosing that I'm having suicide risk, and any kind of discrimination that happens legally, that needs to be changed. That's number 1. Number 2, let's start improving mental health data, which is included by HITECH Act in US, at par with other healthcare data. Mental health is not part of the subsidy of HITECH Act. HITECH Act has put $37 billion behind every other therapeutic area. Mental health is not part of it. And hence, every mental health community centers in the world is at a disadvantage not having the dollars behind it. It is a solvable problem. Garbage in, garbage out is not the solution, okay? And this is the best garbage that we are dealing with. There is a lot to be built on the back of it.
Thank you. We'll take one more question because we started slightly late, but don't worry, we can take it out this afternoon. So there's a question just here.
Thank you. Dave Thompson, Suicide Prevention Lead for the Office of the Chief Psychiatrist in South Australia. Bobbi Jo's last answer there basically mitigated some of my concerns about the language that's being used in this work. We're talking about risk prediction, we're talking about high risk, when the suicide prevention world is moving away from that language. We're moving away from risk prediction. It's about the compassionate approach that we have. Do we think we might get more traction in this work if we change the language around it? Because that's where the discomfort's going to come, about where we get leverage, where we get funding, where we move this forward, and about that overall engagement for people who are within the system and for people who are driving the system and trying to make change.
I have something to say, but I've spoken a lot, so I'll just wait and see if anyone else
to
wants
everybody,
to.
Yeah.
I would say we actually don't call these risk prediction models in our systems when we're talking to clinicians. We call them risk models. We call them detection. We say signal. We use other words because, again, we're trying to stay away from suggesting that this is like the end solution.
Well, thank you so much for all of that. It sounds as though there are some possibilities, but ever such a lot to think about, and you've outlined a lot of those things for us to think about. And I think if you live here, you all know the answer to the question about whether to take an umbrella with you is between September and June, then yes, frankly, is easier. But lunch is about to be served next door, and so we will start again in an hour's time. So do go and have a walk if you want to. There is lots more to come this afternoon, but please join me in big thanks to our panel with Joe, Newal, Bobbi Jo and Dan.